request Dr. Vinit Shah to cover his presentation, Dislocated IOL in the Vitreous, and how will you manage. Dr. Vinit Shah, please. He's a very good vitreoretinal surgeon in Surat.
Good morning, everyone. Thank you, sir, for giving me the presentation and the opportunity. So, when IOL is in the vitreous cavity, so there are no financial disclosures. Despite all the precautions and other So despite all in planning the surgeries, we do see patients where the IOL is in the vitreous cavity, or the entire IOL back complex along with the CTR after a few years is in the vitreous cavity, and even AC IOLs been falling into the vitreous cavity have been seen. So IOL dislocation is reported, like sir said, 0.2 to 1.8% after routine cataract surgeries, and the causes, as I earlier mentioned, is optimal PCR support is not there, zonular dehiscence, pseudoexfoliation, trauma, or a Marfan syndrome. So the preoperative factors which we need to consider while taking up these patients for surgery is like initially we need to assess the patient. We have to see the patient. It is not like some doctor has referred and we directly take up the patient and see the patient in the OR. We need to assess the corneal status, any vitreous in the anterior chamber, whether there is a nucleus or any cortical fragment or IOL which has gone inside, any retinal problems are there, and then take up the patient for surgery. And the second thing is timing of the surgery. There is always a debate about primary as well as secondary intervention in a case of PCR without an IOL in the eye. So studies have shown both primary on the same day or secondary intervention which is done after 2 weeks, both have the same result as well as same amount of complications. So it is not a medical emergency, and we should not directly go in and start operating without assessing the patient properly. And the choice of IOL, as sir previously mentioned, we can use a sutured SFIOL, or the same IOL, we can suture it in the sulcus, or we can go for a sutureless SFIOLs. So my surgical plan always is a complete vitrectomy and explant the IOL, unless it is a 3-piece IOL which can be fixated. Usually I don't prefer monofocal IOLs to be sutured via pars plana routes. And a secondary IOL implantation which we need can be either iris fixated, a sulcus placed, or a scleral fixated IOL. So this will depend upon the surgeon's experience, patient's age, and other cofactors which are present at the time of surgery. So in this case, we can see there is anterior subluxation of the IOL. It's a toric monofocal IOL. And whenever we see such a picture, there is always a temptation that we'll go ahead and bring it out into the anterior chamber without doing a complete vitrectomy. But as you can see, we need to do a vitrectomy around the haptics. It is the haptics are nicely entangled into the vitreous. When we just pull it and fish it out from the anterior side without removing all the tractions, it is bound to occur. There will be vitreoretinal traction, and in future the patient might develop complications. So we need to free the lens completely. Once the lens is free, it will fall freely into the vitreous cavity. I place a PFCL bubble to prevent any macular injuries, and then we can bring the IOL into the anterior chamber and explant it via clear corneal or a sclerocorneal route. This is the second case where it is a pseudo-exfoliation with non-dilating pupil, and the entire IOL back complex along with the CTR has gone inside into the vitreous cavity. The case was operated around 7 to 8 years back, and later the patient had come with this complication. So the same principle, we need to do a good thorough vitrectomy and relieve all the traction surrounding the IOL back complex as well before pulling it out. As you can see, once the traction is removed, it will fall nicely inside. As we can see, entire CTR back complex is there. I made a clear corneal incision, sclerocorneal incision to remove it. But the other thing was that the entire anterior capsule was fused to the lens due to the fibrosis. And when we tried to lift it up just with suction, it was not coming up because CTR, lens, bag, everything, the weight is much more than the suction which can pull it up. I had to do a little vitrectomy and make a opening into the anterior capsule which was fused over the IOL, and then lifted it up with the forceps and brought into the anterior chamber, and then we can remove it. So once we do a complete vitrectomy and IOL explantation, nowadays we are confused by too many IOL options which are available. So like sir suggested, we can use the same lens, we can use scleral fixated, like sutured IOLs, iris claw lens, Yamanese technique or Gabel's technique, or glued IOLs, and now recently this CMT flex IOL has come, which we need to just exteriorize it and leave it. So too many options are available, and we can choose upon our convenience and our expertise which is suitable for us. So surgical principle which should be followed for all is it should be placed correctly into the ciliary sulcus. The haptics should be placed and fixed exactly 180 degrees apart to prevent astigmatism. And the corneal center as well as 0-180 degrees should be marked so that they are all in a straight line. So this is a video courtesy sir who prefers to suture the IOL which is already present inside, and the haptics which are the loop haptics with C shape, where there is a space between the two haptics, we can exteriorize those and suture it to the sclera. So what I prefer is the modified Geber's technique, where we do conjunctival peritomy after marking, do a light cautery at 0-180 degrees, make scleral tunnels 1.5 millimeter away from the limbus, and they are around 2 millimeters in length. Partial thickness scleral tunnels are made. We check the tunnel size and the thickness, partial thickness is good. Then we perform, this is a 25 gauge pars plana vitrectomy, and after completely doing the vitrectomy and removing the IOLs, we'll go for fixation of the IOLs. We enter with a 23 gauge needle at the site of the IOL implantation. Here the light pipe is acting as a scaffold to prevent the IOL from falling inside further. Now foldable 3-piece IOLs are also available, so we can go through a clear corneal incision if we can remove the earlier one with cutting, or if it is a foldable, we can remove it from the same suture side. So once the IOL is in the vitreous cavity, we hold the tip of the IOL and bring it out from the sclerotomy which we have made near the tunnel, and it is just fixated inside. We don't need to put any glue or any sutures for that. The same thing is repeated on the other side, and we can close the case. So the complications which we have noticed are sometimes there is disinsertion of a haptic which needs refixation, which can be done easily. Hypotony can occur, and this is transient due to unsutured sclerostomy sites. Once we patch it for 24 hours, the hypotony and everything also subsides. Rarely some vitreous hemorrhage due to oozing of blood can occur, which also clears within a week's time. And the rates for cystoid macular edema, retinal detachment, and hemorrhagic CDs are same as what we do for other surgeries. So in general, what I will advise is that we need to do a good vitrectomy. Don't pull it blindly. Even before, when we are trying to go for suturing, we need to do a good vitrectomy at the suture sites also, where we are exteriorizing the haptics, because there also the vitreous gets entangled. And once it is done, we can go for sutured or sutureless IOLs, whichever is comfortable. Thank you.
Thank you, Dr. Vinit Shah. Thank you. Now we go to the, yeah, sir, you can continue, but then I request Dr. Rajiv Chaudhary, please come over.
Pointer.
Thank you. Good, good. Anybody like to share some comments?
What lens in cases of, Doctor, you will personally prefer to put? Once your lens is down, you have removed.
Yes, sir. Foldable three-piece.
Mic.
No, once the lens is down, you have removed.
Yes,
the
sir.
lens.